Welcome, everyone. So glad to see so much enthusiasm that we're all here so early. We're going to start early. Hope you enjoyed your lunch. And so today we're going to be talking about how we've used data to achieve efficiency, especially specifically in HIV, TB, and malaria programs with HFG. And as you all know, HFG has worked extensively with countries and help them build the evidence base, use their data to build the evidence to support the reform process. And what we're going to present to you are 3 examples from 3 countries that we have supported in using their own data to achieve efficiency in their HIV TB programs. There's a different scales. So, we have the Dominican Republic, Senegal, and Ukraine represented in the session today. And they're all at different scales, so you'll get a flavor of the kinds of work that we do and how that leads to decision making that is based on evidence. So before we begin, I'd like to just lay out the format. Today we have a panel discussion. We have 3 panelists, including me, so I'm a facilitator, and then I'll do a dance and become a panelist as well. The 3 panelists, and then we present, each one of us will present for about 10 minutes or so, and after that we'd have open it up to questions to you. So first of all, I would like to welcome, let me introduce myself, by the way, because not all of you probably know who I am. My name is Saba Waseem, and I've just recently started as the Monitoring, Evaluation, and Research Director for HFG. I'm an economist by training, but a social scientist by inclination. And most recently, I worked on a Global Fund project, USAID project for Global Fund, and so hence my affinity for HIV, TB, and malaria. And I'm also leading the TB portfolio for HFG right now. So let's begin with our panelists. First up is Nassim, David, Diaz, Casado. He's our COP in the Dominican Republic. So Nassim, please come up. He has over 14 years of experience working in project management. He's an industrial engineer by training, and he's worked for multilateral agencies. And his specialty is project management of health systems. Under him, he's been on the HFG project for over a year, and under him, the DR portfolio for HFG has expanded considerably, and he'll be talking a bit about that. So welcome, Nassim. And then there is Dr. Sophie Faye, who is leading the malaria portfolio for HFG. She's an economist. She is our costing and specialist and economic specialist on HFG. Her work is in the areas particularly of cost efficiency, cost effectiveness analysis, program evaluation. She's been published in peer-reviewed journals. She's worked extensively in the region, and she'll be presenting on the malaria study in Senegal. And finally, I do not want to miss out Olga Zeus, whose work I'm going to be presenting from Ukraine. She is our country manager in Ukraine, and unfortunately she cannot be here because she's busy trying to finish work in Ukraine. She is the one who led the work that I'm going to be presenting. She has over 14 years of experience. She's our costing, economics, health economist specialist in that region, and she's particularly specialized in provider payment mechanism and strategic purchasing in the region. And so she's very highly in demand. In fact, I think she's right now in Indonesia helping them with strategic purchasing with their health insurance. So thanks to Olga, I will present the work that she has done. So I will be channeling Olga for that session. On your desks, on your tables, you've got some handouts. These are just so that when we do the presentation, if you want to have a closer look at the charts and the work that we've done, but it's going to be a more informal storytelling format. We're not going to be doing a very standardized presentation. So let's begin with the Dominican Republic. Nassim, I know that our HFG portfolio in the Dominican Republic was pretty wide. Could you tell us a little bit about the context and the challenges that we were facing, the HIV program faced when you started work in the Dominican Republic?
Of course. Thank you, Saba, and thank you for the invitation. And Good morning to the audience. Good afternoon. I would like to start sharing some information of the national context. The Dominican Republic is a middle-income country located in the Caribbean. This is the second country in terms of territory and number of inhabitants. We have a prevalence of 0.8% of the population, in general population of HIV. That prevalence is focused and concentrated in key populations such as men who have sex with men, sex workers, and migrants. Between 2014 and 2016, the Dominican Republic has notable advances in stabilizing the epidemic. The new infections went from 2,500 to 2,700 in 2016. Instead of that, there's many challenges for the national response, and one of those challenges is the existence of a financial gap for the finance of the national response in Dominican Republic.
Mm-hmm. And there's also the financial gap in the context of the declining international aid in the region, right?
Exactly. The need to expand the existing programs and the limited resources of the government brings the need to design or bring the need to design a strategy for sustainability. For financial sustainability of the national response. And then I will highlight some examples of how HFG contributed to that process.
Mm-hmm. So yeah, and this is an issue that we see around the countries in our work, the financial gap. So how did we help them? How did we help DR address this issue?
Okay, HFG performed and developed many studies that inform the development of a financial sustainability strategy for the country. Those studies included a financial gap analysis, many efficiency alternatives of the national program, some innovative mechanisms to increase the revenues, the tax revenues of the government, and others that were consolidated on a document of alternatives to increase the efficiency, but also to increase the revenues of the government in terms of taxes and efficiency that contributes to increase the whole budget in the Dominican Republic.
Wow, so this is a whole range of studies, but of particular interest to us is the financial gap analysis and the innovative financing mechanisms to maybe perhaps address this gap, right?
All these studies fed the national strategic plan. So not only the financial strategy for sustainability, but also the national strategic plan that is currently in the process of developing. Mm-hmm. Well, as you said, I will highlight two studies that we carried out. The first one is the gap analysis. As we can see, we identify the gap for the national response, for the finance of the national response. That gap is $14.2 million for 2017. As we can see, there's other scenario where the international cooperation decreases. And then the total gap will be around $30 million in 2018. On the right, we have a summary of the results of the alternatives to improve or to increase the revenues of the government. We developed some alternatives that include taxes for the soft drinks. As you know, everyone knows the damages that causes the consumption of soft drinks and sugary drinks, and this is what they call a dual purpose tax. With those suggestions to the government, the revenues will be 7.07 billion pesos. That's around $140 million. It's important to know that this whole scheme was conceived as alternatives to increase the whole health sector budget, but not only the HIV program.
Yeah, exactly. And that's a substantial amount of money that they can raise. So where are they now with implementing these recommendations or findings? What is the uptake at the level of the government?
Yeah, we conceived many strategies for this, including the integration of the ARVs in the Social Security. Yes. So we are currently supporting the country to achieve this that we think is the biggest political change in many years. We are developing a strategy of advocacy with the country, UNAIDS and many other partners to make official by the National Council of Social Security the integration of ARVs in the package of services of the Social Security. So this is an important thing that will help a lot to the sustainability of the country. Also, we share these alternatives with the National HIV Council, but also with the Congress to explore the alternatives of tax reform, including those alternatives that we suggested.
Thank you, Nassim. So as you can see, in the Dominican Republic, we had a wide range of studies that fed into the National Strategic Plan. So it was a big portfolio of work. At the other end of the spectrum of the scale is the work that Sophie did in Senegal. It was one study, but it had a big impact on the way the country is programming its malaria intervention. So Sophie, can you tell us a little bit about the context in which you were working in Senegal?
Sure. Thank you, Saba, and thank you to all of you for coming to listen in our presentations. So in Senegal, the issue that we were facing there is that funds for fighting malaria were decreasing and are still. There's less and less money coming from outside of the country, so the country itself needs to mobilize resources. And on top of that, data for decision making on how to do this resource mobilization or where it's needed was lacking, and especially cost effectiveness data, because this is a type of study that's not being conducted everywhere. So with all of that, we receive requests from the HFG core here in DC to help just shed a light on cost and effectiveness of this intervention, and Senegal was chosen as it is quite advanced in terms of data and how they organize their data to be able to do such a study. But the aim was really so that all the other countries in the same situation can use this example of a study with country-specific data to do their own. So that's how we ended up embarking in this.
So it's exciting to learn that what you did was not really a modeling exercise. You used their existing routine data to help them understand the cost effectiveness of their interventions. So how did you actually do this study?
Yeah, so in terms of the objectives, we really wanted to just compare the different packages that Senegal were using. And I'm gonna just define this concept of package, because we do know that in the malaria world, there is a lot of interventions that you can use to either control the disease or try to eliminate. But in Senegal and following the RBM guidelines, they just decided to package and target, not use everything everywhere, but depending on the incidence level in a part of the country, they would just package a group of intervention and direct it to that part of the country. And what we set out to do was to look at these different packages and calculate their cost and effectiveness so that the country can have more detail in if they want to expand those or maybe they want to change the packaging, how to do this. And just not to spend more time in the methods, but just what we did there was really trying to get the cost of the package using aggregation of cost from the intervention in that package. But also for the effectiveness part, we just use a very common measure, disability adjusted life years, as it would help just bridging effectiveness from both preventive and curative interventions. So I think let me just explain to you the packaging. This will be important for you to understand what we're talking about. And in this slide, you can see the map of Senegal. And incidence is what we are depicting on the map. It goes from red to green, and it gets more serious in the red part compared to the green part. So in the red part, we're looking at incidence of 25 and more per 1,000 population in terms of incidence. And on the other end, in the green side, it's like less than 5 cases per 1,000 population. So you see that the country has different places of it having different incidents, hence the packaging and the targeting. So in terms of package, they had 5 different packages that they were using at the time of the study. The first one is Sophie, Scale Up for Impact. And in this package, you have the most widespread intervention in malaria, LLINs, the nets, IPTP for pregnant women. We have case management at the level of the facilities, but also PECADOM, which is here, case management, but in the community. Sophie is present in the 76th district of Senegal. Now, depending on where you are in the spectrum of incidents, you can get more from the Sophie. So the red packages from 2 to 4, those are packages that are being implemented in red districts where malaria is really prevalent. And then you can add SMC to Sophie. SMC is seasonal malaria chemoprevention, and this is targeting kids 0-10 years to help prevent the disease. Or you can get IRS, indoor residual spraying, or you can get both added to your Sophie. And then in the north of the country where malaria is low in terms of incidence, they've introduced a more elimination type intervention, which they call FTAT, focal test and treat, where as an index case, when they identify you with malaria, they will just go out and test your household and several households around that to make sure that they can detect every cases before it spread out. So these are the different packages for which we were trying to get the cost effectiveness of.
So this is really fascinating. So these are the packages they were already implementing in the country.
Yeah.
So what were your findings? What did you find?
Yeah. So I should say that the study in itself has more than this in terms of finding, but for the sake of time today, we just thought we would share the cost effectiveness ratio findings with you. So remember, the cost effectiveness ratio is the cost per DALI. So how much is it costing for each disability adjusted life years with these packages? And we can see that using a threshold of GDP, which is the guideline that the WHO has for cost effectiveness of interventions, and knowing the GDP per capita for Senegal in 2014, which was the year of this study, we can say that all of these packages are cost effective. Cost effective because their cost effectiveness ratio is less than 3 times the GDP per capita of the country. But the GDP per capita also gives you very cost effective definition, and for that very cost effective definition, you have to have a CER of less than just the GDP per capita. And when it comes to that, then everything but Sophie plus FTAT would be very cost effective. So in terms of cost effectiveness, we want to make sure that we are not misleading here, because we don't want to be comparing the control part of the country where malaria is still very endemic and we are trying to control the disease, to the part where malaria is low, it's more elimination and it takes more resources. So that's why it's very important to make the distinction in the colors and not compare the Sophie plus FTAT to the others, but more likely compare it to the benchmark. right? So, and when we want to compare to the others, our comparison would go toward the control district, where we have 3 different packages going on. Sophie plus SMC, Sophie plus IRS, and Sophie plus both SMC and IRS. And looking at those, we can see that Sophie plus SMC is the one that gives you a higher cost effectiveness ratio. So in terms of investment and what you're getting out of it, it gives you more. So that's really one thing that I wanted to point out.
Great. So what was the uptake? What was the end result of it? How did the malaria program take this on board? Did they change their strategy, especially in the control area?
Yeah. No, the uptake of this was like twofold, because remember I said this request came from Washington Core Malaria. So both of these actors had something to take from the study. So in terms of the core malaria funds, they wanted something that could benefit not only to Senegal but to other countries. So you remember we took an approach of using country-specific data, right? We've seen out there's studies looking at this, but using modeling. Which is great, and sometimes that's the only thing you can do. But if you have the possibility to do country-specific data, this can be an example that other countries can take to do their own and see what's happening in the ground there with the context. In terms of Senegal, it was great too, because the National Malaria Control Program now had this data to advocate for more in terms of what they would do in the north to attain more elimination, and also in the south to better control the disease. So Sophie SMC were found to be the most cost-effective package, and I just came from the MIM conference where I met them, and they were like, now we are negotiating to get SMC in 2 more districts. So they're trying to expand this, and because they had this data, they could show that, okay, what we're doing works, and it works at a reasonable cost. So that was a great achievement for the National Malaria Program. And then another part of the study that we are not looking at here, but which is important, is the cost part. The malaria intervention happening there and everywhere else is being done with implementing partners. So there is a lot of people fighting the disease at their cost, which not necessarily known by the government. And we are talking about transition. We heard it this morning. So we want the government to be able to own all of this and be able to continue doing it. So one thing that they got from this was also a picture of the cost of fighting the disease in their country. Just in case they have to do it on their own, they have the data of what it's going to cost.
Thank you. I mean, that is fascinating. And the fact that you say 2 takeaways for me very important is that they can use their routine data to make this analysis. They don't need any additional modeling or exercise to be done. And that they can learn, other countries can learn from the experience of your study and from Senegal. So let me talk a little bit about Ukraine then.
Yes.
So Ukraine, as you probably know, in the wider healthcare system, is one of the last countries in the region to have gone through through reform, and it has a legacy from the Soviet Union of a wide, extensive hospital network, of which a large proportion are TB hospitals. About 280 hospitals are specifically for TB patients, and they have despite local guidelines, they have almost 100% hospitalization of TB patients. So every TB patient, or even if they're not identified, suspected TB patient is hospitalized. And that's in large part due to the incentive structures. The way the hospitals are paid, they're not paid for the service, or they're not paid they're paid by the number of beds that they have. So the hospitals have an incentive to keep those beds occupied for the longest times possible. And clearly the resources are not being used efficiently at all. So the problem in Ukraine, for TB especially, was not about raising more resources, but to use those resources efficiently. And this is a problem that plagues the system, or that affects the Ukrainian general system as well. And not only is this an issue for resource use, but in the case of TB, this is actually really bad for health. To hospitalize TB patients, it actually has been shown to be a reason for their high multiple drug resistance TB. So drug resistant TB Ukraine is one of the places where it has the highest rate for the region. In general, it is very high for that region, and in Ukraine is one of the highest. And that's in large part because they are hospitalizing, putting them all in hospital. And and these hospitals in turn do not have proper infection control, they're outdated. So it's a problem that the senior, the high level decision makers in the country understand. They realize that this is not working, and that they say that if you hospitalize a patient, if for one infection, they're likely to get another. And so this is a problem that the clinicians, the decision makers all understand, but they did not have the data or the understanding of what the extent of the problem was, especially at the operational levels. And the system, the way it is functioning right now, there is opposition to change. So politically, unless the decision makers or the people, the reformers have the data, they will not be able to argue for change without the data. So HFG was called in to provide support with costing, basically. Yeah. And so what they did was they have lots of data, because if you're familiar with the Soviet system, everything is entered. They have lots of paper forms and things, and they have something called Form 66, in which all the discharge data was entered. So what HFG did was actually create a database of that discharge data, put that data into a database, which is now about 1 million cases in there, entered there, and then crosswalk that data with the financial data. So the clinical data never talked to the costing data before. They put that together and then develop an analytical platform for them. So what we're calling the dashboard, a hospital performance monitoring system dashboard, in 4 pilot regions in Ukraine. And each hospital got a monitoring system where they could see look at different indicators for their own hospital. And that was kind of a revelation for them. So this is an example of the kind of indicator, the kind of analysis that they can do, the hospitals themselves can do, using that data. So for instance, the pie chart on the side shows you that when they look at the types of TB patients that are in the system, they found in that particular hospital that actually 41% of them are non-TB patients. So what they have been doing is that just that incentive to put people in those beds, contacts. So if you're a family member of a TB patient, you're a contact, then you're put in hospital, because in case you develop TB. So 41, in some cases, some hospitals, it was almost 60%. The second chart graph shows them the incentive, the way the incentive structure has been working. This shows, has a graph. One of the lines shows the average length of stay in hospital that correlated with the number of patients. So whenever they have a higher average length of stay, the number of patients is small. That means when the number of patients is small, they keep them in hospital longer. This was evidence to them. This showed them that this is what you've been doing, that when you have fewer patients, you keep them longer in your hospital. The third one is an example of the costs, the cost comparison. So they did costing, and they looked at the costs of different facilities in that particular region and found huge variations for treating that one particular type of disease, the one same condition, huge variations in costs across different diseases. So this is the kind of work that we provided them with, and this is the kind of analysis that we gave them.
Yeah. So what was the result of this in terms of data or evidence that we gave the government of Ukraine?
It was very surprising. And this is another example that we can go back to if you want to. This is a simulation exercise that they did, simulation model for a particular region in Kiev, where they again developed a system that they can themselves plug in variables and see which hospitals are not cost effective, or which hospitals can be rationalized. But as initially, the reaction from the TB authorities, regional authorities, was of disbelief. They were resistant. They said, we do not believe that this is true. But then they realized when they were walked through the data, and our team was very careful to include them at all steps of the analysis. This wasn't just an external analysis, but they were very much part of it. So then they realized that this is truly what they had believed was happening. And for the first time, the clinicians and the managers were talking to the same, had the same data to talk from. And there were a few champions who took this data. For instance, this, if you see the next slide, Dr. Svetlana from Odessa. She was one of the champions of this. She took this data and went to the local parliament, to the regional parliament, and presented it. So HFG actually presented it at the parliament, which is quite surprising, you know, taking data from a hospital to the parliament level, and presented it, and the local parliament saw this and they made decisions about closing hospitals. So they actually, in Odessa, they ended up closing 4 hospitals, integrating them, rationalizing them, putting TB and HIV hospitals together. So they were able to effect a lot of cost savings. And this is happening hand in hand with the reforms in the healthcare system that you might be aware of, that the facilities are not now allowed to retain their earnings. Previously, whatever efficiencies they gained, this was going back to the budget, it wasn't there, so theirs to use. Now they're able to retain the earnings. So for instance, one of the hospitals was able to save $750,000, and that they can reinvest in that one particular TB hospital that they want to improve. So it was really, really immediate impact of it. But we can talk about that later. This is in the context of the bigger change that's happening. And another place where we did the pilot, and Oblast is a region, they actually reduced the number of beds from 4,000 to 758 within a period of, I think, a couple of years even. So this data, this analysis that we did from using their own data, giving them their own tools, because it's a simple Tableau software that has been set up. It's not very complicated. It has empowered them to make their own decisions. So now they have taken it on and they're making their own decisions, and you know, in the context of the reforms that are going on in the country.
Okay. So it looks like we really helped solve that problem for them. But I just wonder about, you know, the next step for the Ukraine government and the MOH, looking at the transition that was the team this morning. How did we handle that in Ukraine?
So Ukraine actually, so now this work that they have done is now, this has gone beyond TB. So the TB people saw this, but now the word is out on the street that HFG has this computer software that does everything. So every hospital wants it. And now HFG has been asked to help with the general hospital system. And the next steps is that they are going to, so this had started off as a strategic purchasing exercise. So now the next step for Ukraine, and they're instituting a national health insurance scheme, and this is moving pretty fast, and they have an ambitious agenda that by 2020 they will have UHC. So they're going to be implementing DRGs, diagnosis-related groups. Yes, for case-based payments. So it will be payments based not on, not for hospitals, but by patients. So the money is now going to follow the patient rather than the hospital, and that's a very big focus of their change. So that's the thing. And in terms of the transition or in terms of sustainability, like I said before, the team has been mindful of working very closely with and empowering the people to use the data themselves by doing it in a way that is completely, so the dashboard that they have set up, for instance, they're very mindful of the fact that their needs will change every year. So it's not static. They can change the indicators as they want and use them as they want over the years. And they have a good team of statisticians and economists in each regional level that is using this already. And we can talk about that later. Linda can give us some examples of how they're actually using it. But I'll stop there and see how.
Thank you, Saba.
Yeah. So, yep, this is, these are our stories, brief examples of what we have done. So now I'd like to open it for questions to all of you. But before I do that, I'd also like to introduce two of our other colleagues that worked with the Dominican Republic and Ukraine team. So Jonathan Cali, he's the country manager on HFG, and he has been working really closely with Nassim. So he's here to answer some questions as well. And Linda Tyson, she is a technical project officer for the TB portfolio as well as for Ukraine. And she was in Ukraine, so she has some first-hand experience of seeing these countries, these hospitals use this, these tools that we set up there. So yes, so now if you have any questions, please go ahead and ask. Any questions? Okay. Bethlehem, I know your name.
Hi.
Hi.
Thank you, everyone. Oh, I have a mic. Great. Hi.
Hi.
Great presentation. Thank you. My question for the Senegal case is, I think you mentioned something about the people using routine data to make their analysis. And I wanted to ask, what are some of the best practices or some of the ways other countries can implement that? Especially in situations where the data is not there and the specialists or there's not a whole team there. What are some of the ways that the data is captured, archived, and used for future research?
Thank you. Do we go question by question?
You go ahead. Answer.
Okay,
Yeah.
all right. Thank you so much. That's a great question. And I think, as I said, this is not everywhere possible, this type of study. But to make it possible, you do need routine data. And I don't know that the Senegal model is the best, but I know that for them, data has been very important. And they've put in place a system which is a parallel system to their own HMIS in the country, where they go in each health facility and they get the data. And this is at a district level, because the way the health system is built, you have the district level, which is the lowest level, and then you have the region, and then there is the central level. So at each district level and each facility on that district, they would organize like a data gathering. Every month, people come from their facility to the district, and they hand over their malaria data. And then that data is checked and just consolidated at that level. And then we do another one at the region level, where all districts then come and consolidate. And once it's done there, then it goes to the central level, where they can just keep all of this data. So be mindful that this means a lot of resource to be expressly put into that data collection. And this means they do have incidence, mortality, coverage data for their intervention in kind of real time, right? So this helped them have this data that was made this study possible. But I would say one drawback is that this is a parallel system, you know. In an ideal world, you want this to be happening inside the HMIS, and not just malaria, but everything else, all the other data that is needed, so that the government can take informed decision at all levels. But you know, for maybe for things that were mostly specific to Senegal, they had to do this, you know, because there was a strike and there were data retention by people at the facility level. So the malaria folks had to be innovative. So they came up with this, and it works. So it's still going on. But I wouldn't say this is how you should do it. I would say we, HFG and other partners, we need to strengthen the HMIS system of the country where we work, so that they can gather all data at the district level, and the data can be up to the central level and used for all type of study, malaria or others.
Thank you. Any other questions? Oh, you can ask, yes.
Hi, thank you. My name is Aaron Pervin. I'm with Results for Development, and really great presentation on the TB purchasing in Ukraine. My question is actually about data sharing among stakeholders and fostering that trust. So in one of the countries I work in, our primary counterpart is the Ministry of Health, and they're much more in charge of quality for TB. However, the data is all housed within the primary purchaser. And so in these instances where you need to foster the trust between the two agencies to improve data sharing, what was your experience in the Ukraine? Did you have something similar? How did you address those challenges?
Yes, and yes, and that's an issue exactly of and that we've seen that in Indonesia, I think also, that the insurance agency would not want to share the data with the ministry, and you know, the ownership of the data is a big issue. In this situation, actually, this was at a pilot level, and there is no real purchasing agency as such that has been set up yet. But in terms of transparency of data, that is a surprising thing. That in fact they are willing to share that data, and they're setting up systems that the data would be open. There is some talk of having this data, at least the summary data or the dashboards being put on their website. So because it has reached the level of the parliament, and it's open, and it's civil society is getting involved, and parliamentarians and legislators are getting involved, there is some talk that once they'd still just install the national health agent, the purchasing agency has just been installed, the head has just been named. They've just set up a national health, public health research center. But the plans, from what I hear, is that if this current minister, who's quite a trailblazer, she has her way, then those barriers will not exist, and the data sharing will be, because as everybody knows, one of the issues in public health or in everywhere is transparency and information asymmetry, and governance is impossible if you have that information asymmetry. And this is one of the big pillars of change that I think that they are trying to get pushed through in Ukraine, but it's a very contentious period, I think, over there for that. Yeah. Any other? Diana had a question.
Yeah, Diana Sillenperry, Apt Associates. I have two questions, if I may. The first one actually is for you, Saba, and Ukraine. I think it's an interesting example of how important data is, and how decisions were made, evidence-based decisions using that data, which ultimately did encompass a number of parties using and seeing the data, et cetera. But my question has to do with the fallout. So, it's a nice, neat slide that shows you need to close 3 hospitals, you're going to decrease the beds in another one. And that's the reality of sometimes, where the data takes us and what makes the most sense. But how did we help the government manage that? And, were there any kind of innovative schemes that came forward in terms of reschooling or, job training or whatever? Because that's a pretty big number of people that probably, I'm assuming, got displaced from their jobs.
Yes.
So that's the first question.
Okay.
I'll give you a minute to think about it.
Oh, no.
Second question. I'll have to think up one more, so you each get one. But no. The second one, Sophie's just in Senegal again. I think that this is really such an important example, and I'm interested to know what we've done, perhaps with the ministry there, to look at sharing and disseminating this approach and the findings. And even though you're right, the data, it was a separate database, but when the data is there from routine monitoring, again, taking it down that line with the packaging and the implications of selection accordingly, seems to me incredibly relevant for a broader number of countries, at least in that region. And I'm interested in what we've done to share those lessons and potentially, link ministry to ministry or whatever.
So should I go first? So I don't have evidence of anything that we did to deal with the fallout. In fact, that's one of the first things that when I was talking about this to somebody else who's a macroeconomist, his reaction was, well, you're closing all these hospitals, but what about the political fallout as well as what happens to the people who are out of jobs, and also coverage? The biggest issue in Ukraine has been against these reforms has been that this is genocide. It's been labeled, the reforms have been labeled as genocide because you are, shutting hospitals that have very low utilization in rural areas, for instance. And they were probably the only places that people would go to because their primary health centers were not working. So those are issues that Ukraine has to deal with. And HFG hasn't done anything of that because we were primarily working on TB money right now. So we've been focused on that. But yes, that is a very important, and that is the reason reforms like these fail. Exactly. But maybe, Linda, you have something else that you know from your time in.
I would say that the concept, although they're not there yet, because this work is still underway, and the idea is that they started in 4 pilot regions. It's not nationwide. There's a nationwide plan, but the idea is that these resources will then be reallocated towards primary health care or some other health need. But that's not the team is working very closely, as she said, with stakeholders and letting them decide what to do with the money. And it was piloted very successfully. What I wanted to say when I was there is, so often we do work and then it just sits. They are so using this information. We turned over, in one of the first pilot regions, Poltava, we turned over the Tableau license. They're continuing, and we went, to the health department, to a hospital, and to a clinic. And everybody said they're continuing to add their discharge patients' data. The head of the health department navigated through that system like nobody's business. He obviously knew, and he's like, well, this is this, and this is this. And he went from page to page, showed us data per hospital, data per region, data for the whole oblast. It was just very exciting to see him really know that program and using it. So that's like the most concrete example of HFG work being put to daily use. And then nationally, they were so impressed that they decided to expand the TB work nationally. So that's actually, we have 5 months left, but that's about 60% done. And they were actually giving the same kind of training that we did for the TB hospitals to regular hospital administrators. And in the training, the part that I was listening to the morning I was there, they were teaching hospital administrators how to use the data, how to collect data and enter it into the same Tableau system to monitor pharmaceutical purchases. So I guess, the HFG team, was very, very involved in the training. And then after they get, a large number of local people trained, they hand it over and let them decide how to manage their future, because that is basically their choice. Yeah. But yes, that's what they've done.
So there was a question for Senegal. Sophie?
Yeah, thank you, Diana. That's a very important question. How do we disseminate this work and make sure that other countries can also use it? So I can say that this work was really, really closely done with the National Malaria Control Program, because there are people there who also are hungry about data and analysis, and they were happy to have somebody, also a project that could accompany them. So they own the study, they know the results. So one thing they've been doing is sharing it among their peers at conferences and also meetings, regional meetings about malaria. So people would come and ask, and they would just share that experience. But also, you would see on the handout, there is a link to a journal article. This is published on the Malaria Journal. So for the community of researchers, they can access the study with more detail. And on the side of our client, the core malaria team here, their idea has always been to help disseminate whatever we get product from this. So to help other countries and make sure that we leverage this, they actually asked us to produce a kind of field guide. A guide that will help countries who want to embark in this type of study with their data on just helping them through it. How do you do it? What type of data you need? Where can you find it? Or do you have to produce it? How are you going to producing it? So that's something that came out of this that we are working on for the remaining of HFG, and we hope that it's going to be very helpful to countries who want to do this type of study.
And in addition to that, we're also doing the country report for Senegal, and we're also doing an impact modeling exercise. So you might have seen in the Learning Lab the work that we did with Avenir, the lives saved. So, what would be the impact of this intervention on the numbers of lives saved? So that will be in the country report, hopefully, in a couple of months. So I wanted to ask Nassim, David, a little bit about the efficiency work that you did. You mentioned some efficiency analysis. If you could talk a little bit about that, and maybe Jonathan can pitch in something, yeah?
As we say, we developed some studies that fit this financial sustainability strategy. And one of them was the efficiency study. We suggested the government not to increase the budget, no alternatives to increase the budget, but to make efficient the existing budget. For example, there were alternatives of follow the clinical guidelines for to ensure the adherence of the clinical adherence to ARVs, making the whole budget for the purchasing of medicines more efficient. Some suggestions around the integration of the purchasing in one central purchase unit that it's called Promesa Cal. We have a central logistic and purchasing unit in Dominican Republic. And other ideas to make efficient the role of the different institutions. We have a singular problem, I think is a common in Latin America maybe, that we have many institutions in the country, in the government, that overlaps their roles. So we suggested several changes to mitigate those overlaps.
Did you have anything to add, John?
Yeah, just John.
I'll just add something on the process for going about the efficiency review. As Nassim said, there's a lot of different institutions in Dominican Republic who are involved in the HIV response. So there's a National Health Service, which is responsible for provision of care, a National HIV Council, which coordinates the response, the Ministry of Health, which deals more with quality and the protocols. There's a National Procurement Agency, and the National Health Insurer Purchaser, many different institutions that are involved in the response. So what we did was we organized several stakeholder meetings where we brought all these groups together. We reviewed all of the work that has been done over the past several years, looking at supply chain and human resources for health and different areas of the HIV response. And we selected a number of issues from that work, much of which had been funded by other USAID projects or completed by other USAID projects. And we facilitated a discussion among all of these institutions to decide which of these options that had been recommended previously are feasible to implement now, and who would be responsible for implementing them in order to realize some of these efficiency gains. Now, as if you've seen in the learning lab upstairs, just recently, HFG came out with a technical efficiency guide, which sort of formalizes this process. And we were part of our work was preceded that, but following a similar methodology.
Nice, great, thank you. Heather has.
I have a question related to that. In your presentation, you presented a slide showing the financing gap for HIV, and then what I presumed through some tax reform ways to help fill the gap through sin taxes. Have you done any modeling on what the efficiency gains presumably would also help fill some of that financing gap? Have you done any modeling on sort of what proportions you're looking at? And related to the sin taxes, it sounds like you're in tax reform discussions now, but will that be earmarked for health, or are there discussions that need to happen to make sure that it actually goes to filling the HIV financing gap?
Okay, maybe Jonathan can add something after, but we didn't quantify exactly the efficiency reforms, but we did quantify the revenues of the taxes reform. Obviously, those changes were conceived as a total reform project, including the tax revenues adjustments, the efficiency, and the alternatives to increase the budget of the government. So maybe as a whole, we had the opportunity to identify the contribution of those adjustments to the national response. Maybe Jonathan can add something.
Yeah, so in later work, we were able to quantify potential savings through improvement in procurement and distribution of ARVs. Right now, the National Procurement Agency is not able to procure drugs internationally, and so the National AIDS Council is in charge of that, and they contract a private warehouse at higher cost than the warehouses that are already run by the government and have space available. So we did quantify some of the potential gains from changing the procurement structure. And in terms of the taxes, Nassim presented to the Health Commission of the Congress in September. They are considering a larger fiscal reform, and there is one congressman who did want to introduce a sugar tax, and has been pushing for that to be included in the larger fiscal reform, and was very interested in the evidence that we produced that quantified the potential revenue from that tax. But as you know, some of these processes move slowly, so there's still a lot of debate about the fiscal reform and what will end up being included in that.
Are there any more questions? No? Any closing remarks? No? See, we're so efficient, we save time as well. But as you can see, I mean, I think one of the contributions, Stella, and especially for me coming from outside to HFG, pretty late, I can see the amount of work that we do on the data side, the analytics side, but also it's not just enough that we also make that change. We make it useful and to the decision makers, and we make that leap. Because just doing analysis and leaving it there, it doesn't make any change. And I think we've been very successful in that. And one of the reasons is, of course, the right time, that you are doing this at the right time and there's demand and buy-in from the government. But also, one of the things that I've noticed is that governments are very careful with what analysis they will use. And especially in Ukraine's case, for instance, our reputation preceded us. So they knew that what they're going to get from HFG, the type of analysis that we'd done in other countries, they'd heard from Kyrgyzstan, other places, and they knew exactly what they wanted. So they had confidence in the analysis that we provided. So to say that, just we did some work and the government didn't buy in, maybe, we have to be also very mindful of the quality that we are producing. And I think HFG has really delivered on the quality. And I think we can be proud of that, right?
Yes, we are.
Yes,
So let's a round of applause for the panelists and for Olga. Thank you. And thank you all for coming. And we'll have reports, country reports available on our website. So this will all be detailed, well, at least summarized in there. Thank you.